Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle.
Hello, guys. A very good evening, good afternoonish to everyone who's watching me. Uh, this is Dr. Pallavi Mahajan, an endodontist, writer, spoken word performer, artist, your host and host for scientific sessions in DRDCA 2020. As I said, as I've been saying, that it has been an amazing experience for me for the whole month of November. It's about to get over, and I'm so sad to be honest. Um, there are a few lines that resonate with what DRDCA became for me in this month of November. Yesterday was Harivansh Rai Bachchanji's birth anniversary. So Amitabh Bachchan's dad, he was a great poet. So he wrote this a very nice poetry in which I'll take two lines from that कि खोज मन का मीत कोई लौ लगाना कब मना है खोज मन का मीत कोई लौ लगाना कब मना है अंधेरी रात पर दीवा जलाना कब मना है. So I think Andheri Raat resonated with these COVID times and these dark times, and DRDCA was actually that light, that actually enlightened my month of November. And I think for everyone who's seeing this, uh, you would have been, looking forward to scientific sessions. I don't know, maybe few of you at least. So that was it. The scientific sessions have been a journey in itself. 40 speakers we had on board with us, and just the two of them are left. And we'll be completing our scientific sessions today, but tomorrow we are going. Tomorrow we'll be there. I might be on the screen, not on the screen, but I'll be there witnessing, awards night that we have been planning. And all the people of all the founding members of DRDCA will join us, and it will be fun. So having said that, let me introduce you to the speakers that we have now. The first speaker that we have, Dr. Rangnath. He is a prosthodontist and implantologist. He is going to provide us an insight into techniques of implant impressions, like all on 4, all on 6 will also be highlighted. Dr. Rangnath completed his post graduation in Bapuji Dental College and Hospital and is currently working as professor in Krishna Devaraya College of Dental Sciences and Hospital, Bengaluru, with 15 years of teaching experience. He has previously worked in Mumbai as an academician, practitioner, and as a consultant. He is currently the executive member of Indian Prosthodontic Society and editorial review board member of Journal of Indian Prosthodontic Society. His keen interests are in the field of dental implantology, cast partial dentures, FMR with smile designing. He has various publications to his credit, and presented various guest lectures in conferences and workshops. He's keen and passionate for biodegradable and sustainable biomaterials, and currently in research and development of bio-based face shields and bio-based toothbrush, along with his school friend to whom he attributes his success in his developing career. So as I've been mentioning, the question and answer session will be the will be post the discussion gets over. So without further ado, I welcome Dr. Rangnath on the screen. A very good afternoon to you, sir.
Very good afternoon, Dr. Pallavi Mahajan, Dr. Roxan. Dr. Roxan always rocks with his Dental Reach magazine and conferences and so on. Dr. Nupur Sri Rao, who is the scientific convener of this. Namaste to everybody. So I am here for presenting a scientific session on an insight into techniques of implant impression. So Dental Reach Digital Conference and Awards during this COVID situation has been implemented, and through the brainchild of Dr. Roxan, we had IDA conferences previous year in Ramaya Medical College, Ramaya Dental College, Bangalore, and then in Mandya. So in COVID situation, IDA has taken geared up with conferences in its live format, and through this DRDCA 2020. So DRDCA 2020 had many good speakers, which I just came across from many people, from Sijal Jacobson from Australia, Dharam Hinduja was there, and Sundar Jagadishan, and many people, very good presenters had presented many good topics. Very good afternoon. Namaste to everybody. So I can proceed with my presentation?
Sure, sir. Yes, sir.
Yes. So the topic today is on insight into techniques of implant impressions. As a layman, let us keep the dentistry aside. As a layman, when we first think about the word impression, what do we think of? This is what I usually ask all my students when they just come into the undergraduation. What do you just think about impressions when you just hear the word impression? So the first thing we get it in mind is about the thumb impression. Something impressions made in the clay when we were playing during our childhood days. Impressions made in these dough atta, what we call. So these are the impressions which gets imprint. So whatever objects negative likeliness is there, these are the one which takes up into its negative likeliness. But only thing is that this imprint, because the material has no dimensional stability, it gets distorts. It changes its dimensional stability. So we, the dentist or the dentistry field, has certain excellent materials wherein it not only makes a negative replica, but also holds that negative replica with its dimensional stability. So we do have so many materials, and by this impression, we do make a lot of processes. So impression has a major role in fabrication process, in fabrication the processes, in the material role in prosthodontics. So as a layman, when we speak about something about chewing gum, yes, it is also taking the negative likeliness of the imprint, but the chewing gum doesn't have that dimensional stability. So this is what we as a layman think about impressions. What I'm actually speaking about today is the implant impressions. Implant impression, you have a lot of implant components, wherein where to use and when to use and which is the material that we use is what is being covered in this particular presentation in a very simplified way, so that there is a minimization of the doubts for the participants who are there here. What are the learning objectives with this seminar of about 1 hour? We are understanding different implant impression techniques, closed tray or open tray impression, and abutment level or implant level impression, all on for or multiple implant impression. One novel method which I have done a study, so that is what I am going to just highlight in today's presentation. We are appreciating the use of appropriate impression copings and verification jigs while we are making impression. We are speaking about something about splint and non-splint method of implant impressions, when to splint and when not to splint for the better accuracy. We are speaking about custom implant impression when we are dealing with aesthetic zone, aesthetic implant zone. And all this 4 objectives I am going to cover with my demo through 3 videos, one video demo on snappy abutment impression, one video demo on closed tray impression, one video demo on open tray impression. Then I'm going to brief on multiple implant impression, as I told, a novel method which I have done a study. So I also cover this with a video demo on all on 4, or you can take it as a multiple implant impression. I go through the digital implant impression. So these are all the learning objectives. And as we know, Journal of Prosthetic Dentistry says a negative likeness or copy in the reverse surface of an object, an imprint of the teeth and adjacent structure is nothing but the impression, the definition of the impression. Now, what do you mean by ideal impression? Ideal impression should be in the mind of the dentist before it is in his hand. The operator should make the impression rather than take it. So whenever we write maxillary impression taken during our college days, our faculty member used to say that it is not take it, it is make. It is make. It is make. There was a correction to the word from take to make. Why is this so? This is because making an impression is not just a procedure or a task. It is a science. And why do I call as a science? Because while making an impression, emphasis is given to the biologic landmarks. And it is not just the impression material you take, you load it into the tray, make the patient open the mouth and insert the tray with the material and wait for the material to set and say the set impression in the tray as an impression. You make an impression. Impression is planned. What I mean to say is impression is planned. It is made with scientific basis. So let me speak about the basics first. Let us take the complete denture impressions. As you are all very familiar with the complete denture situation. How do we make impression or plan an impression in complete denture? I'm emphasizing once again the word plan an impression in complete denture. Planning an impression in complete denture is by using the tissue stops. You can see the tissue stops over here depending upon the different clinical situations. We plan the partial spacer, full spacer. You provide window sometimes when there is a flabby tissue. Sometimes whenever you are making an alginate impression, you give a genopassamanti spacer. So these are the spacers that is having a scientific basis for a complete denture impression where the load is being distributed for stress bearing area and the relief areas through these spacers and the tissue stops, and there is a scientific basis for this kind of an impression. Let me come to removable partial denture impression. Here also we make impression or plan impression in removable partial denture. How do you do that? By planning the support, and giving emphasis to tooth bone areas and tissue bone areas. So you have tooth bone areas and the tissue bone areas, you have residual alveolar ridge. We call these tooth bone areas or the anatomical areas, and we call these ridge areas as the functional areas. You see to that when a cast partial denture is inserted, your rest is seated completely in the rest seat, and also the denture base is completely seated onto the residual alveolar ridge without any much gap. And there is a load distribution both in this tissue area, and there is a load distribution through the rest along the long axis of this supporting tooth. So for this, you need to plan an impression. So you have a lot of impression techniques in the removable partial denture, like dual arch impression, altered cast technique, functional relining method, selective pressure impression with using different viscosities of impression material, and so on. So this is about removable partial denture impression. When you come to fixed partial denture impression, how do you plan? You plan the fixed partial denture by planning the registration of the finish lines. You have done such a beautiful tooth preparation. When your finish lines are not been recorded properly, there is no value in making the tooth preparation so efficiently. So you plan the impression so that you do some retraction methods, soft tissue retraction methods, and capture the same in different viscosities of the impression material. So this is how you plan for a fixed partial denture impression. So science of implant impression is also the same. Science of implant impression also to be known, and it is my today's attempt to make understand the different implant impressions technique in a very simplified way. And during the initial stage of our implant practice, always there exists an element of doubt regarding which implant impression technique to follow and in which clinical condition, which components to use and which technique to use. So all this I need to slightly cover the basic terminology about the components of the implant, the abutments and other things. So let us go very briefly on the basic terminology of implant. As you know, there are two types of implant. One is the single piece implant, another one is the two piece implant. Single piece implant, where the abutment and the implant or the fixture body is unified. You cannot separate this. So when you place the implant in the patient's mouth, the fixture is gone into the residual alveolar bone, and the projection part, the abutment is above, and the projection part is above. And this projection part will be used as a support, for your crown or the superstructure. Whereas the two-piece implant has an fixture or the implant body and another unit where there is an abutment which gets inserted into this. So when the fixture is inserted into the bone, when you're doing a two-stage surgery, you open the flap and then you put an abutment and then make the impression. So this is the two-piece implant. So the other piece of the implant might be in the form of cover screw during your surgery. During your second stage surgery, this gets replaced by an healing cap, and then during the prosthetic stage, this gets replaced by an abutment. And once again, abutments are of different types, which I'm going to cover in my later slides. On the abutment, you are going to put an crown. To brief on this connection, whatever is there, it could be an internal hex connection or an external connection. Today's available implant systems are more of an internal hex connection or a conical connection or some other different Morse taper connections and advanced connections are all available. External hex are available if you are looking at something about an all-on-4 kind of a superstructure, you have an external hex connection. So moving forward, this is cover screw. What do you call cover screw is placed after the stage 1 surgery. Yeah, when a two-piece implant is being placed, the fixture head is inside the bone. You place a cover screw, you close the flap, wait for about 6 weeks to 3 months or 4 months of time, depending upon the primary stability what you have achieved. You take a clinical judgment when you do the second stage surgery. Till then, cover screw covers this fixture or the implant. Above that, the flap gets sutured. So this is the function of the cover screw. What do you mean by healing cap? Healing cap is the one component of an implant which extends above the soft tissue. So this develops an permucosal seal. So during the second stage surgery, you just give an incision to this flap. You give a circular incision through the laser or through your scalpel, open that, take out the cover screw and place the healing cap. So this healing cap is available in different collar heights. So based on how much is the biotype of the soft tissue, the thickness of the soft tissue, collar height of 1 millimeter, 2 millimeter or 3 millimeters. So when you place the healing cap in place, so this gives an emergence profile. So this is the emergence profile that is there. You get it in different forms: wide emergence profile, narrow emergence profile, depending upon the area which you are working in, anterior, premolar or the molar area. This is very important, impression copings for our today's lecture. So this impression copings fits on to the implant while making the impression. So the impression coping transfers the position angulation of the implant fixture. There are two types of impression coping. One is the closed tray impression coping and the open tray impression coping. The third one is a custom impression coping, which I'm going to deal in detail in today's lecture. So closed tray impression coping, I have put a slash over here. It is also called as the transfer type or indirect transfer coping. Open tray impression coping, also called as pickup type and direct transfer coping. Custom impression coping, also called as aesthetic impression coping. Why is this called transfer type? Why is this called pickup type? Will be dealt in the next slides. Coming into the closer look of this closed tray and open tray, to brief up, Closed tray impression copings are in flush with these cylindrical hollow cylinder. Open tray impression coping, the screw is extending far above this cylindrical structure. This is in flush. This stays within the tray. This part of the screw gets projected outside the tray. That is the reason why it's called as open tray, and this is called as a closed tray. This doesn't gets projected from the impression tray. This gets projected from the impression tray. Closed tray impression coping, or the transfer type, or the indirect transfer coping. An indirect impression coping uses an impression material which is of elastic property. It is screwed into the implant or the abutment body. So when you are speaking about the closed tray impression coping, when you have planned for an impression with the closed tray impression coping, you place this impression coping in the patient mouth and you make an impression. When you make an impression and when you pick up the set impression, this particular coping stays in the patient's mouth. You get only the indentation. You get only the indentation on the impression. So for that, for the easy removal, for this to stay in the impression, the closed tray impression copings has parallel sided, or it is usually a slightly tapered one without any undercuts for the easy removal of the impression. Why? Because this stays in the patient's mouth when you make an impression. After you take out the set impression, this closed tray impression coping stays in the patient's mouth. The operator will transfer this from the patient's mouth and snap fit into the set impression. So that is why it's called as you transfer the closed tray impression coping from the patient's mouth to the set impression. Whereas open tray impression coping consists of a hollow transfer component. This is the hollow transfer component, and a long central screw is there. So this long central screw gets projected from the set impression. So when you make an impression, you actually unscrew this, and when you take out the set impression, your open tray impression coping gets picked up from the patient's mouth into the set impression. There is no need for the operator to remove this from the patient mouth and then snap fit. It gets picked up. So that is the reason the open tray impression coping are also called as pickup type kind of an impression coping, or a direct transfer coping. Direct transfer means impression will pick the component. So that is the reason called as direct transfer impression coping. So you have abutments. Abutment is that portion of the implant that supports or retains the processes. When we speak about the single piece implants, we speak about that the portion of the abutment that gets projected. And when we speak about for a multiple implant impression, the one structure that runs from one abutment to the other abutment is called as a superstructure. In case of an hybrid processes, over denser kind of a processes and other things. There is a component called as analog. Analog is something that is analogous or replica of the implant. When you have transferred through your impression either by using open tray or a closed tray, whichever technique you have used, you need something, a replica. Patient mouth has implant which is made up of titanium. A similar kind of a replica which is made up of brass, aluminum, steel has to go into the model, which replicates the spatial position, what is present in the clinical situation. Same situation is being replicated in the model. So through these replicas, through the position of these replica, you are going to plan your processes. That is your implant analog. Superstructure is defined as that metal framework which runs from one implant abutment to the other implant abutment and provides retention for the processes. So this is the superstructure. Could be in titanium, could be in chrome cobalt, could be 3D printed, could be casted. It can be even from the latest materials like PEEK superstructure or PEC superstructure. Okay, PEEK stands for polyether ketone and PEC stands for polyether ketone. So these PEEK and PEC, which comes from the PEEK family materials, has good amount of resiliency, which has the capacity to absorb the loads. Okay, it's not as rigid as titanium or as rigid as cobalt, chromium. Now, for a successful implant impression to be made, there exists this communication between these implantologist, technician, the patient, and the material. What does that? One is the patient cooperation, 3 factors: knowledge of the implantologist, skill of technician, the property of the material which we are using. Now we will come to the impression techniques. Now, accurate recording of the spatial implant position is required to obtain a proper support to definitive restoration with passive fitting, as described by Conrad et al. In 2007. So here I'm mentioning the word spatial implant position, which I'm going to elaborate once again in my next slide. The critical aspect of the spatial position is to record the 3-dimensional orientation of the implant. You have 3 axes: x-axis, y-axis, and z-axis. Every angulation of this implant, what is present in the patient mouth, is to be replicated, or is to be transferred, or is to be recorded in your definitive master cast. So that is the spatial implant position. So when you have recorded an accurate spatial position of the implant, you can expect a passive fit of the processes. We don't want an active fit of implant processes. We want an passive fit of processes. So we are all speaking the accuracy in terms of microns. So for today's digital technology, earlier it was all about casting, wax structures, burnout, casting, and all. So there were some mismatch in terms of setting expansion, the shrinkage of the alloys, and other things and all, where we were more dependent on slicing the processes, once again joining by welding and soldering for achieving better passive fit of processes. All those have been minimized. So hats to the digital technology, hats to stereolithography, hats off to CAD/CAM, hats off to these intraoral scanning machines and all. So dentistry is growing, it's reaching its heights. So the era of dentistry, whoever is practicing now, they are like very blessed and very much enriched with the technology in this very skillful practice. What should be the goals of an implant impression? One is the position of the implant, recording a proper soft tissue contour, recording the proper axis, rotational hex position, and then the depth of the implant, whether it is supracrustal, subcrustal. All those is to be considered when you are making a better impression. So when we are speaking about the classification of the implant impression techniques, there are 2 things. One is based on the level where impressions are made. One is the implant level impression or the abutment level impression. And based on the type of coping used, open tray technique or the closed tray technique. So you have abutment level impression or implant level impression. I will call abutment level impression as regular FPD impression, closed tray impression or open tray impression, a transfer impression or closed tray transfer impression or closed tray transfer. Transfer impression or closed tray transfer. So we will come to abutment level impression. What do you understand by abutment level impression? I do call this as a regular FPD impression. Where do we use this? This is similar to the impression made in tooth supported fixed partial denture. So any modification, if it is necessary, it is made intraorally and the impression is made. Now you don't do any kind of an impression. Abutments are there. You just capture the details of the abutment. You mill the abutment intraorally itself using the burrs, and then you make an regular FPD impressions. Like for example, if there is a single piece implant for this congenitally missing lateral incisor is being placed, the labial aspect and all are being trimmed by using the burrs, like tri-hawk metal trimming burrs, and then the clearance at the incisor level is also achieved intraorally, and whatever modification is necessary, it is done intraorally, and just you make an impression. So this is how a single piece implant, you can appreciate a single piece implant for this minimum bone that was there, minimum bone width that was available. That is the reason single implant was being placed and the impressions were made, and this is how the lateral incisors were being replaced. What is the indications of this abutment level impression? One is the single piece. Whenever you have used a single piece implant where you cannot separate the abutment and the fixture head, if the indication is if the implant is placed in a very ideal position and only minimal abutment modification is necessary, you can use this abutment level impression. Temporary abutments, two-piece, and provision for temporary crowns. Abutment level impression can be used whenever you are planning, whenever you're giving a temporary crowns on temporary abutments. So you just fit the temporary abutment, which is made up of aluminum, do the intraoral trimming, and then you go for a temporary crowns. When you go for a temporary crowns, you can even plan for progressive loading of the prosthesis. And most of the basal implants or the strategic implants are all about this abutment level impressions. So basal implantology has more often single piece implants. Nowadays, if you go to mono implant and other basal implants, there are two piece implants, but most of the basal implants are all dependent on abutment level impressions. What are the contraindications of this abutment level impression? You cannot provide a screw retained prosthesis in abutment level impression. Only a cement retained prosthesis can be provided in abutment level impression. What is the advantages of this abutment level impression? One is open tray impression requires your copings and extra structure and other things. So wherever the clinical cases with limited mouth opening, with inadequate space for making a pickup impression is there, you can use abutment level impression. Supposing patient is having an exaggerated gag reflex and the impression has to be removed very quickly as possible, then you use an abutment level impression. So in an open type, closed tray or open tray impression, you spend some time for removing or unscrewing the impression copings, where the patient cannot tolerate if she's or he is having an exaggerated gag reflex. There you use abutment level impression. Technique is very generally simpler and quicker and economical. Most often economical. This is the most common reason why single piece implants are being used in an ideal position and then the abutment level impression are made, because the inventory is very less. The inventory of other additional components is less. Abutment level impression disadvantages: when you are doing abutment modification intraorally, when you take the burr, you just placed a single piece implant and you take a tri-hawk burr or an metal trimming burrs and then try to trim this metallic portion, there is a chance of heat transfer. And once there is a chance of heat transfer, what is going to happen is that the bone implant contact interface, okay, so there is a chance of a lot of insults that is there in the BIC interface, and that is one disadvantage. And when you're intraorally trimming without a mill or a surveyor in a freehand format, obtaining parallelism between the two abutments is much difficult. So for this kind of an abutments intraorally trimmed, provision for only cement retained processes is the only possibility over here. So these are the disadvantages of abutment level impression. So we dealt with indications for abutment level impression. We dealt with contraindications, advantages, and disadvantages of abutment level impressions. Let me come to implant level impression. So I think abutment level impression is clear, and we can take the questions at the end of the session. And also there are handouts, and there is the same content is going to get published in the next Dental Reach magazine edition. So probably you can have a refresh or relook into the material or the literature of this particular presentation. So let me come to implant level impression. Implant level impression involves registering the spatial position. So you are registering the abutment implant assembly in terms of its axis, depth, and position, what exists in the oral cavity, to the master cast, to the working master cast, using impression coping. And this impression coping could be a closed tray or an open tray, and you use an implant analog to fix that. So two methods of implant level impression are there. One is closed tray impression and the open tray impression. I will repeat that: closed tray implant level impression and open tray implant level impression. Why am I repeating this closed tray implant level impression and open tray implant impression? Because most of the students, wherever I have taken the courses, they get confused that all the closed tray impression is like abutment level impression. Abutment level impression is a separate entity, and implant level impression you can classify into two, which you can categorize into closed tray implant level impression and open tray implant level impression. So I'll move to the next slide. Now, implant level impression as in general per se, what are the advantages? One, clinical cases with multiple implant impressions. There are multiple implant impression. You cannot do an abutment level impression over here. Clinical cases with divergent implant angulations. Divergent implant angulation, the possibility to make impression is the implant level impression. So when you are expecting, when you want to achieve the passive fit of the prosthesis superstructure in multiple implant restoration, full mouth rehabilitation cases and cases with all-on-4 treatment protocols, implant level impression serves better. So these are all the multiple implant impressions. What are the disadvantages? Impression needs additional components. You need an additional components, hence not cost effective is a disadvantage. And technique sensitive. So technique sensitive, so there needs some training, maybe 1 or 2 impression, that's enough, or certain kinds of seminar kind of a thing which we are doing today might help you brainstorm in the implant level impression, and straight away you can make impressions very, very effectively in the patient's mouth. So now implant level impression, I am going it in detail for closed tray impression technique, closed tray implant level impression. I will repeat, closed tray implant level impression, also called as transfer impressions. As we said, closed tray impression are those impression copings where the screw is in flush with this, impression post. You have a flat surface in one of the sides to leave an indentation on the registered impression. So you have a flat surface. Characteristics of closed type of impression is that impression coping remains in the mouth on removal of set impression. So I think you understood this. Characteristic of closed type impression is that impression coping, this impression coping remains in the patient's mouth after the removal of set impression. So only the impression with the indentation is there in the impression, and the coping is there in the patient's mouth. So coping is there in the patient's mouth, it is not picked up. Okay, so operator should go to the patient's mouth, unscrew that transfer coping, and then using this flat surface as an indentation, he is going to refit, or he is going to snap fit in the impression. So here the retained impression coping is removed from the mouth, and implant analog is attached. So once you remove the impression coping, you fix the analog to the impression coping, and the impression coping analog assembly, this assembly is replaced in the indentation. You just find some indentation, the flat surface indentation in a good light, and then you fit that. You're going to fit that in the indentation. Hence this technique is also called as transfer impression, because you are transferring the impression coping from the patient's mouth to the set impression, also called as repositioning method. So the repositioning method is one of the very common MCQs that is asked in the postgraduate entrance exams. Okay, so it's also called as transfer impression or repositioning method. So custom tray is not mandatorily required for this type of impression. Stock tray is okay for this. Stock tray, why? Because you're using a putty impression or a putty impression material, and then a light body impression material in one phase. So this gets transferred, you get an indentation, and you transfer the impression coping. So implant level impression by closed tray impression techniques, there are 2 techniques. One is using closed tray impression coping, another one the plastic snap fit impression coping. Now plastic snap fit is an advancement in closed tray implant level impression, first introduced by these Nobel Biocare people, called as snap fit impression coping. So this is an additional terminology. You have closed tray impression coping, you have open tray impression coping, you have snap fit impression copings also. So snap fit is nothing but closed tray itself. So you can call it as a closed tray implant level impression, which I am going to describe here with a video also. Now, this is the technique using the closed tray impression coping. This is once again the repetition of the same. Okay, the impression coping is removed manually, repositioned into the impression. It is important that the coping relocates positively, and it is critical to ensure that the geometric details of the impression coping is recorded accurately in the impression. So you have to check for the indentation and then fit. Okay, so this is how it is. So you have a flat surface here, flat surface here. You made an impression, and with the fixture and the analog assembly, you have repositioned this in the impression. Now I come to the plastic snap fit impression. This is a plastic snap fit impression, like in Noble Biocare. What we have, plastic impression coping has a press fit kind of an assembly onto the abutment. So on the abutment, you have a plastic press fit with these horizontal serrations, vertical undercuts, so that this horizontal serration is get caught into the set impression. And when you're removing the impression, what happens is this plastic part will go into the impression side. If you observe this here in the patient's mouth, the snap fit is there, abutment. On the abutment, there is a snap fit of the plastic snap fit on the abutment. When you made an impression with these horizontal serration, it gets picked up. Though this is a closed type, this is not an open type once again. Though this is a closed type, this gets picked up. This has an indentation. So this, for your repositioning, this is going to guide you. This is going to orient you for your implant analog assembly to refit. So there is no need for you to put light and check for the flat surface of the indentation and other things. You have readily available snap fits, which is much easier. It goes in only one direction, so the errors are minimized in this closed tray kind of an implant level impression. Closed tray kind of an implant level impression. Now we come to the open tray kind of implant level impression. So this is called as pickup type of impression. So there is no need for, earlier was called as transfer type of impression. This is the pickup type of impression. Why? Because operator, there is no need for the operator to transfer the coping from the patient's mouth to the set impression. Impression itself will pick the impression coping. So how is this mechanism? Here the impression coping or impression post is long. It is long to get projected from the tray. Characteristic is that it gets removed from the mouth together with the set impression. They require access to the retaining screw. This is the access to the retaining screw. This projected portion of the screw from the set impression is one which you are going to unscrew before you remove the set impression tray. Analogs are attached to the impression copings. To this, you are going to attach the analog and then you pour the model. So these are called as the pickup type of impression. So here you could use custom tray or an appropriate stock trays. Stock trays are also available with different vents. Okay, so different vents or the sliding holes kind of a system. Okay, so those stock trays can be used, or a plastic tray. You can just make hole in the plastic using a straight fissure burr and can be used as an impression for implant level open tray kind of an impression. Now, open tray kind of an implant level impression, there is a need sometimes to splint and there is a need sometimes not to splint. So if there are less than 3 implants, no need to splint it, because inter-implant axis, what is there might be some micro movements. So to minimize those micro movements, you splint this and then you make an impression. So in some cases, these copings may be splinted together intraorally to provide greater rigidity and possible great accuracy. To achieve great accuracy, you do the splinting. So splinting can be done by a dental floss or your self-cure acrylic resin or your old burrs, okay, or a stainless steel rod, stainless steel wire. So you can splint the inter-implant impression copings and then you make an impression. Non-splint method, when there are less than 3 implants, non-splint impression, open tray kind of an impression can be done. So this is the open tray, custom tray that is used. All these screws are getting projected here. When the polyether impression is set, you unscrew this. Once you unscrew this, the open tray impression copings gets picked up in the set impression. We now go in, is it clear, Dr. Pallavi, everything?
Yes, sir, it's clear. Everything
Yeah,
is
yeah.
clear.
So now I am going into the one of the three videos. The first one is about the snappy implant impression. This is the closed tray kind of an implant impression. I just run through this video. If there is anything about the sound and the music, if the music is high, you let me know. If the sound is high, you let me know.
Sure, sir.
Yeah.
Sir, can you explain with the video? I think the audio is not coming.
So audible is not there.
Yes, sir. Can you explain with the video, sir?
Yeah, yeah, I will do that. So this is an impression. This is a video to show you about the snappy abutment impression. So this is the snappy abutment. This is the snappy abutment. You select a tray, you put tray adhesive, you bleed the silicone, light body adhesion silicone, put it in the patient's mouth. Consider this as the patient. So the model, we are considering this as a patient. This is the Noble Biocare snappy abutment. So putty is loaded onto the stock tray. Either your assistant will mix the putty, you load it onto the tray. So the stock tray carries the high viscosity putty impression material. You make the impression. So you make the impression, and once the impression sets, so you remove the impression. So here is where you can appreciate the snappy has come to the other side of the set impression. You have the indentations over there. So this is the indentation you can appreciate. So now you are very much clear that my abutment I can easily fit without any errors. So here I'm going to unscrew this. So I unscrewed. Abutment is in my hands. I am going to take an analog. We call this as an abutment analog assembly. Analog. So this is the analog and the abutment. This is the Noble Biocare abutment. So I'm tightening this. So once I do tightening, so this assembly, what I'm going to do is, I don't need any light or to check the indentation of the register, this thing, because the plastic part is already there and it goes in one direction with a snappy sound, click sound. So you just click that into its position. So this is the closed tray kind of a implant level impression. This is a closed tray kind of an implant, snappy kind of an implant level impression. So we go to the next video. Here where is the closed tray type of impression. Here there is no snappy, but we are all dependent on this flat surface. I'm trying to show you the flat surface that is there. Okay, this is the high-tech implants which we were using earlier. Can you see this triangular hex over here? This is a flat surface. So this is a flat surface which you appreciate, and then you place it in such a way that it is either labial or buccal, because the implant is also placed in such a way that the high-tech implants, one end of the hex is in the labial area or the buccal area. Here you tighten it. You appropriately select a stock tray. You apply tray adhesive. You block these when modeling wax. You flush that so that no impression material go inside that vent. and cause inaccuracy. So once it is blocked and it is in flush, you load the high viscosity putty impression material, put light body in the patient's mouth, and you make an impression. So when you remove the impression, you are actually checking these flat surface in a good light. In a good light, you take the assembly. You're actually checking the flat surface for a proper registration. Now the impression coping is in the patient's mouth, so you are transferring it. That is why it is called as transfer type. So you are transferring it. So you remove the wax that was previously used to block. You get access to the whole screw. You unscrew that. Take the abutment and then the analog. You make an assembly of that. And holding the analog, what you do is, holding the analog, you are transferring by checking the flat surface, and just you press so that you get a click over there, and that is how you transfer the closed tray type of an implant level impression. Closed tray type of an implant level impression. So this was our second video. Coming to the third video, I'm speaking about the open tray type of impression. There are 3 implants over here. So good that I will be able to show you how to do a custom tray by using acrylic tray material. You must have heard self-cure material. There is also called as self-cure tray material, which you use it to make the trays. So here is where the modeling wax is being warmed up so that you are blocking to fabricate the tray, space for the tray. Horseshoe shaped onto the master cast. So you make the tissue stops, put some aluminum foil onto this. I'm being given 1 hour of time. I think if I show the full video, but I'm showing you the full video, but with the steps. So tin foil, I'm going to rub, expose the tissue stops. This is how the tissue stops are getting exposed. You mix the tray material. This is the tray material, polymer and the monomer. You mix it, wait for its wet stage, stringy stage, sticky stage, dough stage. So at the dough stage, you block this for the tissue stop, knead the material, and you make the custom tray. So good that you are able to see how to fabricate the custom tray, and the tray is trimmed, wax is removed, mark the tray extension, trim the tray. So now what you're actually doing here is you are putting open tray impression copings. So as you remember that these open tray has an extension. The screw gets protruded out. Okay, so the screw gets protruded out. You apply the tray adhesives. You bleed the light body in a glass slab and then put the light body impression into the patient's mouth, considering this as the patient now for the demo. You make the impression. You can see the tray has holes here as marked in this marker pen. The holes were made, and before this sets, using a thumb or a forefinger, what you do is you just make the access for these extension screws to protrude, so that you have access for your hex driver to unscrew this before you remove this impression, before you remove this set impression. This is how you make an implant level open tray kind of an impression. So you are unscrewing this now. So once you unscrew this, you remove the impression, and this is how all the four impression details are available in this open tray kind of an implant level impression. Open tray kind of an implant level impression. So this is the 3 videos that we covered. So coming to the custom impression copings, Dr. Pallavi, everything going good?
Yes, sir. All good.
Yes. So now we're coming to custom impression coping. Where do we use this custom impression coping? Supposing we are working on an aesthetic area. In an aesthetic area, we do sometime use these immediate implant placement where you extract the tooth, healing socket is wider enough, and your impression coping is narrow. So there is a space in between the coping and the healing socket. So that is also to be registered. So for a proper emergence profile, when you don't do that, what happens is it gets collapsed. You have not registered it properly. So you customize the impression coping by adding some layer of composite waxes or pattern resin or some other material which is inert, which is not going to harm the biologic tissues, and then you make an impression such that you get a good emergence profile. So this is the custom impression coping or aesthetic impression copings, what we call. So I come to the multiple implant impression. Classic example is all-on-4 impression. Whatever explanation I give for all-on-4 concept will be holding good for multiple implant impression also. So this is where all-on-4 impression came into picture, where if there is a deficient maxilla and mandible, where there is no possibility for placing more than 4 implants, 6 implants, 8 implants, but still for a fully edentulous case, we have to go for implant supported prosthesis for a better better prosthetic value of for the patient. We can use this tilted implant as described by Palomalo, wherein you give a mesial tilt and you increase the cantilever, and on these 4 implants you can give a full arch prosthesis rehabilitation. So there are some guides. In 45 degree you place the implant such that it engages the mesial wall of this maxillary sinus, and your abutment is somewhere over here. If you had placed straight, the abutment would have been here. Okay, prosthesis reaching till 6 would have been difficult. So now in this particular situation, you have only one cantilever, one tooth cantilever, which is much acceptable. Okay, that is the advantage of all-on-4 concept. And in other case where there is good amount of maxilla and mandible, you can place 4 here, 8 implants, 3 here, and 6 implants. Impression remains, impression technique remains the same. But what I'm describing here is for all-on-4 implants, all-on-4 implant impression. So use of tilt abutments is fundamental for this rehabilitation, as it allows many things. One is implant support is moved posteriorly. Implant length can be increased. By giving a tilt, the length of the implant can be increased. So you have better primary stability. Okay, anterior wall of the maxillary sinus has high density bone, enhancing the primary stability. That is advantage. Desired position of the implant is determined from the prosthetic point of view. Desired position of the implant is achieved. Favorable inter-implant distance is there, and small cantilever is also there for a better superstructure. Okay, so this is the superstructure that is designed for this particular case. Okay, so here you use, when the implant is placed in an angulation, you use multi-unit abutments. What do you understand by multi-unit abutments? Abutment is been angulated at 45 degree. The axis of the implant is actually like this. The axis of the implant is actually like this. You have access for this particular screw and this screw. One screw is one thing wherein it is called as the implant abutment screw, and other screw is the superstructure and the abutment screw. So these type of abutments are called as multi-unit abutments. Now when we are using multi-unit abutments, conventionally what we were doing is just make an impression by flossing, by splinting method and other thing. What I'm trying to explain over here is that I'm introducing one primary impression for this multiple implant impression, so that there is an ease of access, convenient for the operator. A study was been done, and it was found very relatively convenient for the operator. So technique A is one conventional method. 4 implant unit abutments were placed. If you consider this as a 4 implant abutment implants, these are the holders that are very much parallel, Okay, so you make a jig of this. You make a jig of this. That means you splint this, and by, as I explained, as an open tray implant impression, you just make an impression of this. You make an impression of this. So here what is happening here is this flossing, this splinting part, whatever is there, you are doing it in the patient's mouth. Okay, there is some time that is being spent for flossing. There is some time for pattern resin to get incrementally to add in the patient's mouth, with the patient mouth open with the saliva and other things and all. So that is all being minimized in my technique B. That is a novel method where I am introducing an primary impression for multiple implant level impression. Okay, let me go further with this conventional method. You just make an impression as I showed you in the demo of multiple implant impression. This impression is made. Okay, this is the impression, final impression, and the obtained cast will serving as the master cast. This is the master cast. In one impression, you got the master cast. So this is the novel method. Now, in this method, we are introducing one called as introducing a primary impression. What we are actually doing is that we are using a standard, not multi-unit implant impression copings. This is a standard open tray impression copings. Okay, so standard open tray impression copings, you place it in the patient's mouth. You make impression just by a putty impression material. You got a primary cast. You just got a primary cast. All your analogs are according to the internal hex that is there in the patient's mouth. So once you got the primary cast, on this primary cast, what you're actually doing is you are able to assess the collar height of this, the tissue biotype, soft tissue thickness, the angulation, what angulation you want, whether you need 17 degree or 34 degree. In earlier case, in the patient's mouth, you were actually checking the 17 degree, 30 degree angulations. We do not know which angulation gets fitted. And when we open the inventory, 17 degree or 34 degree, the inventory is getting wasted. So all that you can try out by trial in the primary cast. All that trial and error you can do it in the primary cast before you go to the patient's mouth to make the final impression. That is the advantage of this. So you select the appropriate angulations, 30 degree, 17 degree, till these holders or the impression copings comes parallel, and then in the primary cast you do the dental by using the floss, you splint this. Then on the floss, you put the pattern resin, you splint these open tray impression copings. That is the open tray impression copings of multi-unit. Okay. Earlier for primary impression, we have used standard open tray implant open tray impression copings. In the primary cast, what we are using is multi-unit open tray impression copings. There is difference here, standard implant impression copings and multi-unit open tray implant impression copings. So on the primary cast, you use the multi-unit implant impression copings, splint it. Okay, this splint is carried it into the patient's mouth. The entire assembly is carried it into the patient mouth. So this was fabricated in the primary cast. So your time spent in the patient's mouth when you are doing a final impression is very, very less. You have already fabricated the custom tray here. So you have adequate space for this entire assembly in this indent. So you have your splinted thing ready. You have your tray also ready before you go into the patient's mouth. That is the advantage. You have the tray ready. This entire assembly is carried into the patient's mouth, and you make the impression. So when you make this impression, this is the master cast what is obtained. This is the master cast what you obtain. On this master cast, your superstructure gets fabricated. Now, in the earlier technique, without using the primary cast, when the superstructure was been fabricated, there are possibilities that you might have to do the intraoral sectioning of the superstructure, do the welding or thin crystallization, and then once again pick that as an impression because of the errors, because of the not achieving the passive fit. So all those errors can be minimized by this introducing this primary impression in this multiple implant or the all-on-4 impression, wherein the possibility of this non-passive fit is minimized, and you get a very passive fit of the processes with a very good success of your either of your hybrid processes or any superstructure processes. That is the advantage of this novel method of impression. Now, what are the advantages of this primary cast? One is selection of multi-unit abutments with appropriate color height. You are determining all of the color height not in the patient's mouth, not in the bleeding and with the saliva tissue biotype, but you are determining the height and ordering for these color height appropriately after assessing in the primary cast. After assessing the primary cast, there is no need for you to take a periodontal probe, go to the patient mouth, check the collar height, order a different collar height, and then once again reorder another collar height. So all these are being minimized. Selection of multi-unit abutment with appropriate angulation. So there is no need for you to check this angulation in the patient mouth. You sometimes go wrong in the patient mouth when you're selecting the angulation. So you can do this in the primary cast itself and then order for an appropriate multi-unit abutments. You are doing the pattern resin jig extraorally. You are fabricating the pattern resin jig extraorally and then carry it into the patient's mouth. Adequate space in the final custom tray for splinted multi-unit open tray. So in the tray is so well designed in the primary cast so that the corrections that is through your handpiece is very minimal, because already an adequate space is available here for in the custom tray. So this is how the adequate space is there. Appropriate vents are getting protruded. You just make an impression with proper support, okay, and the impression that is getting registered through the already space available is much more accurate than the conventional method. Reduces chairside clinical time. Patient comfort in reducing the duration of mouth opening. So you are not making the patient open the mouth for a longer period of time. That is the biggest advantage. TIG trial accuracy followed by metal trial framework is better. Accuracy of impression, accuracy of spatial placement of implant in the impression, operator's comfort. So operator and patient comfort both is there in this technique. So when we did this study by doing by placing the implant in the model. This is the milling surveyor that was used in angulation. Implant was placed. Okay, special tray was been fabricated in both these technique in two different impression material. One is polyether and one in additional silicone. In technique B, this is a novel innovative technique, material polyether, material addition silicone. Okay, so in coordinate measuring machine, when it was being checked, so the method with the novel impression technique, introducing primary impression with polyether showed to be a better technique of making an all-on-4 or multiple implant impression. So this is the video to show this all-on-4 novel method of an impression. So appreciate this multi-unit abutment. This is the holder. This is actually the implant axis. So when you place this, the holder is here. This is the axis of the implant. This is the screw, which is the abutment implant screw. And the above screw is the superstructure abutment screw. Here where is the one which fits the superstructure. So this is axis of the implant actually. Correct? This is the implant axis. Long axis of the implant is this. But this is an additional screw which will support the superstructure. So that is called as multi-unit abutments, available in different collar heights. So these are the holders to check the parallelism. So appropriately you take 17 degree, 34 degree. Nowadays Bioline has 34, 40, 45, 50, 55, 65 degree multi-unit abutments. In the pterygoid cases and all, they are all used. So this is the anterior straight abutment holder, just to ensure how parallel it is. So what we are actually fitting over here is the multi-unit implant level open tray impression coping. So that is an external hex system which gets fitted over there. So multi-unit implant level impression coping is placed. So this is the, consider this as the primary cast. So where you are doing everything extraorally, splinting has been done. This is the pattern resin from GC. So you use the pattern resin to splint the open tray multi-unit implant impression copings. Sorry, I'll just go back. So this is how you do the splinting. So you use the brush, apply on to that floss. Now you're fabricating the custom tray on the primary cast. So you get to know the wax spacer that is being given, and you get to know how to do the custom tray in light cure acrylic tray material. So this is the wax block out and the tin foil application. This is the material, acrylic light cure tray material. So this is one part. So surrounding the splinted, you are applying the wax so that there is no undercut. You get good amount of space for your material. So once you light cure that, you remove the impression, trim the trays. Sorry. So you trim the trays, appropriate vent holes are being given in your custom tray. Apply tray adhesive. So rubber based impression material, you mix it, you need it in a vinyl or nitrile gloves. You bleed the light body silicone. Now you are working on into the patient's mouth. Consider this as the patient. You put light body, make the impression through the use of your putty on the custom tray. Before the material sets, give access to the screws. Unscrew the implant open tray multi-unit impression copings. So once the material sets, you remove this, so you got the final impression with good details of 4 impressions, or consider it as many implant impression. Multiple implant impression. I'm sorry. So now you place the analog and screw and tighten that. So this was about all-on-4 or multiple implant impression. Let's come to the digital implant impression. Now, digital implant impression itself is a separate webinar. Lot of developments with regard to digital implant impression. Nowadays, I use all CAD/CAM intraoral implant impressions itself. So, digital implant impression, in brief, if I want to just brief you with this, is one wherein you use the intraoral scanner or the extraoral scanner. You have the sensors onto the abutments. So through the intraoral scanners, it captures the spatial position of the implant. So one of the system is the PIC system, that is the PIC camera, precise implant capture. PIC stands for precise implant capture, stereo photogrammetry method. So I just run through this video and then so you are using the intraoral scanner. So for the digital implant impressions, I'm currently using this BioLine sensor implant impressions, so quite good. And some CAD/CAM and stereolithography impressions intraoral technology has given much precision. So summary of my today's implant insight into techniques of dental implant impressions. We got to know about impressions in dental implantology, basic terminology in implant impressions, goals of implant impression, different implant impression techniques. We appreciated the use of abutments and verification jigs. We gone through all on four impressions or multiple implant impressions, demo through videos and digital impressions. So this was about the implant impressions. I acknowledge the Indian Dental Association, Dr. Shivsharan Shetty, Dr. Ranganath Venugopal, Dr. Satish Reddy, and Sudarshan Sajjan sir for the great association. My friends Dr. V.K. Manjunath, Dr. Prasad MGS, Dr. Dayakar sir, and Dr. Sadanand. The Dental Reach, my good friend Dr. Roxanne Samuel, Dr. Nupur Shri Rao, Dr. Pallavi Mahajan, and all from Dental Reach Digital Conference and Awards 2020. Thanking you. If any doubts are there, kindly clarify. And the summary of this particular presentation is also available in the next publication that will be briefed by Dr. Pallavi Mahajan. Thanks very much.
Thank you. It was an amazing presentation, sir. As you can see in the comment section, that you have made it so simplified that the whole I'm an endo, but I've never taken implant. I've never placed an implant and not taken impression, but I've seen doctors struggling with it. So I know how, whom to, which video or which session to get back to when I want to learn this, or maybe tell somebody to go through it. So thank you so much, especially those
So
videos that you have
nice.
made.
So nice of you. Thank you very much.
So shall we move ahead to question and answer session?
Yes, yes, please.
Okay. A question. I'm not sure if you have explained. I think you have explained this, but I'll just put up the question. Please
Yes.
give overview of full arch implant impressions for FP3 prostheses where implants are multiple but not all on four.
Yeah, the technique remains the same. Once you speak about FP3 processes, FP3 processes covers both your soft tissue and then the hard tissues. So you are concentrating more on the soft tissue biotype, your emergence profile and the structure, the smooth surface in the processes that is given. So it is the same multiple implant impression using open tray, splinting the things, and then if it is an immediate implant placement, open tray impression copings is to be customized with some material so that it occupies the space in between the soft tissue and the impression copings, right? And then you make an impression and register that appropriate soft tissue biotype is where the challenge is. So in my presentation, what is that all on four or multiple implant impression I've just mentioned.
Right.
So that holds good for the example in the demo is given for all on four. That could be 6 implants or 8 implants also.
Okay. Another question. What about implant assisted cast partial dentures?
Implant assisted cast partial denture. So very simply, to explain it in a very simple way, now we do have many lectures on during your third year BDS removable partial denture, a chapter called as support for distal extension partial denture. Support means like you have class 1 distal extensions as a saddle situation or class 2 distal extension saddle situation where the posterior teeth are not there, or class 4 which is of high span. So there you can plan for a implant assisted cast partial denture wherein you have placed some 2 or 3 implants in each quadrant of your class 2, okay, wherever the distal extension areas are there. Supposing if you have placed 2 implants in the right distal extension area and left distal extension area another 2 implants, you can place 2 locators and give support for that distal extension area and provide cast partial with cingulum receipts and a framework which is having a bilateral stabilization. So that is the implant assisted cast partial denture. So you use locators or ball attachment in these implant.
Okay. Okay. Another question, sir. If we are giving implant supported removable dentures, which impression technique should be used?
Implant supported
Removable partial denture.
removable partial denture. Once again, I will go for the implant level open tray impression technique with splinting, because the structure, the overdenture framework is running from one implant to the other implant. The inter-implant distance should be maintained, should be registered accurately. So you do splinting. After you do the splinting, the entire assembly of the splinting should be captured in your open tray impression technique. So after you do that, and once you got the superstructure, the framework that is running from one implant to the other implant, you check for the passive fit. For the passive fit, and if there is, if you not have achieved a passive fit, then probably you will section in between where there is no passive fit, and then once again you rejoin. Once again you do a pickup impression, do the welding and other areas in that particular area, confirm that passive fit, and then go for the acrylic superstructure. So instead of doing extraoral welding, there is something called as intraoral welding. What you call it as syn crystallization, SYNCR, syn crystallization. So that is a tool wherein you can do the welding intraorally itself. So if you go wrong, but if you have a proper impression by doing splinting and open tray impression techniques and all, that situation doesn't arise.
Okay. Okay. There are two questions from Dr. Nupur. One question is, in the novel technique,
Yeah.
can you please explain how you got the primary cast?
Primary cast, yeah, this is nice, good question. But still, I think many people will be having doubt in this.
Yes.
So I will tell once again that think that some 6 or 8 implant has been placed maxillary. We don't know. Everything is been done free-handed, not in a surgical kind. So we don't know. All implant has a different angulations. Okay, it could be 17 degree, it could be 30 degree, or even placed pterygoid side, some 45, more than 45, 60 degree you have placed the implant in the pterygoid area. Now here you play around in the patient mouth for determining the biologic tissue height, determining the angulation, what to select and what not to select. So, but instead I make a primary impression. How do I make a primary impression? You just put all standard open tray implant impression copings, standard, not multi-unit one. We have not gone to the multi-unit level only. Just take standard implant impression copings, put it in the patient mouth, just in an open tray, not very precise, just make an impression, just pick up impression in a putty impression material. Once you got a putty impression material, you have transferred all those spatial position. You put standard analogs, not multi-unit impression analogs. You put standard implant analogs. Okay, multi-unit impression analogs has external hex at the superstructure, but in your primary cast, it is the internal hex that is there. That is your standard implant impression copings. You do, you pour the model. On that poured model, that is the reference for you to check the angulation. You take to check the soft tissue height, how much it is. You do all this to order the inventory. Order the inventory in terms of the selection of color height, ordering the inventory in terms of angulation of the multi-unit abutments. So for ordering, you do all your homework in this primary cast. So in this primary cast, the second objective is you are fabricating a custom tray. You are fabricating a jig or a splinted multi-unit impression, multi-unit open tray impression copings you are going to put, wherein you check all the holders to be parallel on the primary cast. You put the floss, splint it, your final custom tray is ready. So the entire assembly of this splint, you carry it in the patient's mouth, it gets fitted over there, you tighten that entire assembly instead of fabricating in the patient's mouth, instead of doing it in the patient's mouth. The assembly you carry, you fit it in the patient's mouth. There, if you have anything in the pattern resin, if you don't have any fit properly, you can just take a straight fish rubber. It is easy to cut the pattern resin. Intraorally only, you take some amount of pattern resin in a dough stage, paste over there, you ensure the passive fit, take out the assembly, once again place the assembly, ensure the passive fit. Then using the custom tray, final tray, you make the secondary impression. So here you are minimizing the patient's chairside time. Your inventory is under your control. You are not ordering a wrong angulation of multi-unit abutments, wrong angulation of the collar heights of the multi-unit abutments. So your errors are getting minimized. So
Right.
I think I am able to address this to Dr. Nupur.
Yes. Another question that she has is she has a case of bilateral distal extension
Yes.
wherein implants are placed posteriorly, teeth present anteriorly, and
Yeah.
one molar is present on right side.
Okay.
There is less interocclusal space. How
Hmm.
should she make the impression, and which prosthesis is advisable, removable or fixed?
Difficult to say this unless I see the OPG or the model. How much is the supra eruption that is there? We do not know. So according to the description, as you say, it is the only one molar that is there. All others are implant. So if one molar is there, it is better to extract the tooth, or you have to plan something. If more than one natural teeth are there, probably you can do sectional FPDs on the both the sides, or you can plan for a cast partial supported implant supported cast partials interimly till these teeth are retained. So I think I should see the clinical scenario and then
I think
judge
Dr.
that case.
Nupur can contact you and
Yes, yes, sure.
share the images with on email or something like that.
Yes, 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 we'll do that.
Okay. One question I'll ask it from my side as a beginner.
Yeah,
Sometimes it happens that when we take impression, we go wrong with the impression.
yeah.
So, what would you suggest? Shall I make space for light cure material, take the re-impression on that one only, or remove the full and take a new impression?
I am always even like I always go for repetition of the impression rather than correcting the same impression.
Okay. Okay.
So that's
Okay. So those were the questions. Thank you so much for the wonderful presentation. And
thank you.
I guess any people who are going to see this will have a lot of questions later on also, so they can anytime reach out to you.
Sure, sure, sure. No problem.
So there
And
are many viewers who are just best presentation simplified version. Thank you so much. Very well
thank you.
explained.
Thank you very much.
Thank you, sir. It
Thanks
was
for all the
an honor.
audience. Thanks for the participants.
Thank you. Thank you, Dr. Ranga.
Thank you.
So that was Dr. Rangnath with us, and I hope I forgot to mention to him, but I hope that he joins tomorrow for the event for the awards night that we are planning to have. So, guys, that was Dr. Rangnath, and I think a very important topic. Sometimes we talk about implants, we talk about processes on implants, but a basic technique of taking an impression, we often think that okay, not a big deal, but it is, because as I said, I have seen people struggle, I have seen prosthodontists struggling with it, I have seen, I myself have never done it, but yes, I am sure when I'll start, I'll have my own set of doubts and questions. So this will definitely come into my rescue. So thank you so much to Dr. Rangnath for being here, and thank you for you guys to put up the questions, and for all the comments. Thank you so much. The next
Okay.
speaker that we have, I'll give his intro with few lines. This is
Yes,
a
bro.
poem. This is a poem by Robert
Yeah, yes.
Frost. I have already mentioned this. I have recited this earlier
We'll
also.
try. We will
It's one
try.
of my very
So we will try.
one of the poems that I really like. Road not taken.
Okay.
So I'll just recite the few lines of. So two roads diverged in a yellow wood, and sorry I could not travel both. And be one traveler, long I stood, and looked down one as far as I could, to where it bent in the undergrowth. Then took the other as just as fair,
Oh.
and having perhaps the better claim, because it was grassy and wanted wear, though as for that the passing there had worn them really about the same. And both that morning equally lay in leaves no step had trodden black. Oh, I kept the first for another day, yet knowing how way leads on to way, I doubted if I should ever come back. I shall be telling this with a sigh, somewhere ages and ages hence, two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. So the next speaker that we have is Dr. Kevin, who's going to speak about digital, who has taken a road less traveled by and ventured into digital marketing and digital branding in dentistry. So hear it from him. So let me tell you about him. Dr. Kevin is going to join us from Philippines. He is the founder of Dr. Kevin Mirasol Pro Digital Marketing. Which is a social media marketing agency for healthcare and business owners. Um, He has also founded Dr. DM Masterclass, a dental digital marketing coaching for dentists. He's a dental digital product developer for social practice bundle, dental social media content calendar, dental chatbots. He's a dental marketing coach. He has various publications and presentations to his name. He has featured in Met 2019, featured in DentaCoin 2019, resource speaker in dental marketing Philippines, launched July 2019. He's the first dentist partner of DentaCoin in the Philippines. As I said, he's also has his own private practice in Philippines. He's going to tell us about dental social media branding, something I think which is need of ours, especially in COVID times. Everybody is struggling. Once we come back, everybody is going to need some tips and tricks on how to manage their social media and their dentistry. So I guess without further ado, as said, questions will be taken up at the end of the session. And guys, this is the last session of the last scientific session of DRDCA 2020. So please be here, tag your friends, and yes, let's hear it out from Dr. Kevin. I hope he is there on board. Good evening, doctor. Hello, Dr. Kevin. Am I audible to you?
Hello, can you hear me, guys?
Yes, yes,
Good
you are
evening.
audible.
Okay, thank you for that very nice presentation, Doc.
Thank you,
But
Dr.
can you see
Kevin.
my screen? No.
Yes, I can see you. Are you sharing your presentation also right now? I can see you, Dr. Kevin. Okay, I think we are having some network issues. So let's wait for him till it gets sorted. Sometimes it happens, you have to end and so what is it? Wash hands? Okay, Raj Divan is written something. Okay,
Hello.
hello, Dr. Kevin, and you are back.
Hello, doctor.
So,
Sorry, I'm just having a hard time with my internet connection.
no issues. I was about to say no issues, but let's see. Be here constantly for this session, and Dr. Kevin will just come in and in between. Let's see whenever he joins. Till then, guys, um, whenever he joins, I just stop speaking because it's hard sometimes. Just stop in between. But anyways, if you have not registered, now it's no time, but still you can. Do fill your, feedback form. Feedback form is there on the app. You have attended the conference. You have seen all the hard work that especially Dr. Robson has been doing and the whole team back in team has been doing uh, you know, uh, having conversation with all the speakers, getting them on board. So please give the feedback. Dentists do require a feedback, but then when we organize a conference also, then also feedback is required so that we can plan something on this level once again. So do leave your feedback, guys. And okay, I'll just tell Dr. Robson that whenever Dr. Kevin joins, just let me know. There is some network issue which happens, especially here and international. Some networks. Um, anyways, guys, Novolive's laser therapy machine. We had a lecture in the morning and where we discussed laser. Yes, yes, Dr. Uday, you will get certificate. So you guys can
Hello,
ask.
guys.
Yes,
So,
hello, Dr. Kevin. Yes. Yes, Dr. Kevin, we can hear you. Hello.
no,
I guess this.
it's really not good with my connection. I'm sorry.
No, no issues.
I
Am
think
I
maybe
audible?
because of the weather here.
Okay. Because you are audible to us now. So are you going to take presentation like this? Because we cannot see you, but we can hear your voice. And it's gone now. Okay. I'll answer Dr. Uday's question. You will get certificate. Uday, you need to fill the feedback form. You can see the comment. The link is there. And feedback form you'll get and fill the feedback form and certificate you will get after 2 weeks like conference ends tomorrow, so after 2 weeks you will get the certificate, so you will get it, be assured, but do fill the form. Those who have not registered, you won't be getting certificate. There's still time, those scientific sessions are done, so please, but still if you want certificate and you have not registered and you have attended scientific sessions, kindly register yourself. So my feedback on all the scientific sessions, I can no, I cannot say my favorite, but I will ask people who are listening to this conversation, who are seeing me live, please tell me your favorite sessions. Let's see the favorite sessions. Let's see. Okay, Dr. Uday, you tell me your favorite sessions. What and all you have attended. So, guys, okay, I'm an endo, so I'll be very partial. I liked all the aesthetic and endo sessions because I could understand them very clearly. I like the ortho session too. I like today's implant session. So there are a lot of sessions that I like. The only thing what happens is me, with me, the you ask, the more interesting the session becomes for me, because that is what I enjoy more, rather than just seeing the presentation. I like conversing, answering questions, speaking to speakers. So that is what, actually, when I was young, I planned to become a journalist. So yeah, I guess that this comes from there. Dr. Rumpavik, yes, I must say, the biomimetic and all those things, plus the way she presentation, I still remember a few slides. It was very nice. Yes, Dr. As I said, aesthetics and endo any day, but some for the topics that I'm not aware of, the basic presentations like today's, which Dr. Rangnath took, it was like, I will start my journey from here. Okay, so Dr. Raj Devan is saying laser, Dr. Yavagal best session. All the speakers were too good. I agree, Dr. Uday, right? All the sessions were too good. So I'm going to revisit them, guys. In fact, Thursday session was Dr. Rohit Shetty was there, Dr. Nikhil Bhaguna was there. So aesthetic, you need armamentarium, as I asked in that question and answer session also. But you have to start from somewhere. And as Dr. Nupur asked, um, my favorite session of, I think I will tell my favorite part of the whole scientific session was, to get to know about so many speakers, especially reading their, the CVs. The reason is, sometimes you are very confused, as to which way to go. So yeah, that helps. So thank you so much to DRDCA for having me here. That is a poet speaking on my part. Um, so let me see if Dr. Kevin is here. Let me ask. It was a wave of knowledge, true. That is so sweet. It was a wave of knowledge indeed, Dr. Uday. And Dr. Nupur, let's talk about contests. Actually, I wish you could be here, and I really want to talk about contests, because there were contests in which poetry was there, singing were there, dancing was there. So many people, many doctors have sent their, uh, what you tell, their audition kind of small clips. So yeah, exactly, Dr. Nupur. If I would not have been in the organ in as a a host, I would have sent my poetry for selection. So yes, thank you, Dr. DRDCA IDA. So as I said, there are many contests that are happening. Contests, many entries we got, and we'll be giving awards tomorrow. So stay tuned, guys, for that at 4. It start at 4, and I'll also try to join in. Maybe for some time. Let's see if I can. So what we'll do is, okay, since Dr. Rangnath finished his lecture, and as he mentioned, his article is going to be published in the next edition of Dental Reach Monthly Magazine. So you can, go through FB page of DRDCA, and we'll keep posting everything about the articles, the monthly subscriptions, any events that we are coming forward with. Do remember, guys, it's just a conference that is getting over. Dental Reach is there, will be there, and we are, it is for the service of dentistry, for you guys, for getting more knowledge. So get, be in touch and listen, see all the articles that are going to be published. There's all Dr. Kevin, who was supposed to join us now. um, so what we'll do is, his article is already there in October session of Dental Reach magazine. So you can go there and check the article, and we'll post the session tomorrow, because today it's taking a lot of time. It's taking little time for him to join. There is a network issue which happens, when we are talking about online events. It does happen. So we'll be posting his session tomorrow on the FB page. Meanwhile, you can just go through FB page, go through the app. And yes, a very important thing, Novolace laser therapy machine that one lucky person will get. We are going to, the winner will be announced tomorrow 4 p.m. You have time till midnight today, okay, tonight, basically 12 o'clock. You have to send your entries if you haven't sent. All the details are there on FB page, DRDCA page. Please go and send your entries. बाद में नहीं बोलना कि नहीं मिला या नहीं कंसिडर किया. So do that, okay? So these were the things that I really wanted to say. And so tomorrow is awards night. Do join, guys. Tomorrow 4 p.m. awards night. I'll also be there. I'll try to join and I'll try to recite something for you guys. So on which note, I would like, actually, I would take this time, since Dr. Kevin is not going to be here. I will take some time and I will thank the whole team of DRDCA, Dr. Nupur Shirao, Dr. Roxanne Samuel. There's a long list. So yeah, Dr. Nupur Shirao, Dr. Roxanne Samuel, Dr. Zainab, Dr. Rahil, Dr. Akshay, anyone who have missed, former member Dr. Manu Man. So thank you, Dr. Ashwini from Dental Divas, who actually was the first point of contact between me and Dr. Nupur. So thank you, thank you, thank you for giving me this chance. I'm going to miss these scientific sessions so soon. And we will plan some special sessions soon. And Dental Reach has just started now, so it is going to be here. Always keep sending on the app. You can find all the details of all the speakers, their email addresses, everything. So any doubt you have, you can go and ping them directly, or you can reach out to us at drdca2020 at the rate of gmail.com, or dental reach at the rate of gmail.com. I might have gone wrong with email addresses. Please check it out on FB. And as Dr. Nupur has mentioned in the comment section, website for digital publication is www.dentalreach.today. So you can go there. October issue is there. November is speaker special editions. So those will be there. You will find article of Dr. Kevin there in October edition, of Dr. Rangnath, of Dr. Sigal Jacobson, of many other doctor speakers also. So okay guys, the session, I've been waiting ki kuch aa jaye. That session is going to happen, but session is not there today with Dr. Kevin. We'll be postponing it to maybe tomorrow. We'll post something. Otherwise, soon we are going to do this. And for articles, dental news, DR podcast. In fact, I also have submitted one podcast. And webinars and educative videos, go to Dental Reach today, www.dentalreach today. On that note, thank you so much for being so patient and listening to me. And I will say something about myself also. As I said, I'm an endodontist and a poet. You can follow me for my poetry writings on Pal Poetry. So that's it from my side. This is Dr. Pallavi Mahajan signing off, guys, from Scientific Session DRECA 2020. See you tomorrow at 4 for awards night.